non-syndromal part needs to be taken care of by clinicians, at least in the OPD cases. The most common example of dual diagnosis or comorbidity in depression and alcoholism. Okay. Now you don't need to look at only the ADS, dependent syndrome, or people with syndrome and depression. But in patients with alcoholism or alcohol use disorders, please look for depressive features. Don't miss them. In people with depression, CMD, OPD, please ask about alcohol or tobacco use. Most often we don't. When we are dealing with alcohol drug abuse, we keep questions of alcohol drug abuse. When we are dealing with depression and anxiety, we keep questions about depression and anxiety. I think there needs to be really a lot of clinical interface between CMT, SMT to lesser extent, and SUD, the non-syndromal type. Which brings me to the third major point. Since the morning I have been waiting, except for a passing reference by Dr. Kala about tobacco and alcohol being dangerous, more harmful than other drugs. In terms of dual diagnosis or comorbidity, there has been no reference to tobacco or now caffeine. Please appreciate, and my senior and contemporary colleagues might want to share their experience. In a whole lot of patients with anxiety and depression, syndromal or non-syndromal, alcohol, tobacco and caffeine is a very important role player. How the symptoms modulate over a 24-hour period or over a few days, and how they respond to treatment. So my third major strong point is please always have on your radar and on the radars of your PG students inquiry about alcohol, tobacco and even caffeine for patients of depression and alcohol. And in your advice and treatment, please include this. Patients, the kind of patients that Dr. Deepak Raheja sees, they might most often ask. But middle class or the lower middle class patients will not even ask you. It will be our duty, it seems to be, that we bring that interaction to their notice and say, look boss, your caffeine use, your tobacco use, your alcohol use will affect your alcohol and depression. And we don't do that. My last point in that series is this. Like Dr. Shivgautam mentioned very well, ICD and DSM, I think naturally doesn't mention dual diagnosis because they encourage multiple diagnosis. So for ICD and DSM both, multiple diagnosis is not only permissible, it's encouraged. So why should they talk about duty? There are situations where we need to train our PGs and we need to practice deviations from ICD DSM system. And the first major thing is, while current classificatory systems seem to tell us, try and make as many diagnoses as permissible, the old style that Roop and our generation used to follow, Mir Saab and Hamlo, is now passé, where the teaching was that you try and explain all the symptoms under one syndrome. Here you make 4 diagnoses. I think there has to be a deviation from that when it comes to comorbidity and diagnosis, because if anxiety or depression or any of the psychiatric symptoms is a part of the withdrawal or the SUD, you cannot be making additional diagnosis unnecessary. Let me give you a simple one research finding about this, and it was 50 years ago. In 1972, and somebody raised this question in Shivgautam's lecture, I have made a note. Who was that? Some gentleman who was asking, should we treat immediately? Mark Shukit established in 1972 disorders and started treatment. I agree with Dr. Shivgautam when we start treatment even in the first 2 weeks. But as a general rule, please monitor for 2 weeks that these symptoms, psychiatric symptoms, are not part of the withdrawal. The second deviation that we have to make from ICD and DSM, and this again was alluded to, is this primary-secondary dichotomy. Again, same example. Does the person primarily have alcohol dependence and secondary depression? Or does he have RDD or bipolar or chronic depression and alcoholism is a secondary effect of that? ICD and DSM do not encourage us to make primary-secondary dichotomy, and as signatories to WHO, we have to follow that. But in clinical practice, you don't have to follow the WHO manual so much to the letter. My suggestion and very strong opinion to all of you, is that primary secondary dichotomy, even if current systems do not encourage, we have to keep on our clinical skills because it's very useful to differentiate A leads to B or B leads to A for clinical decisions, spatially management. So that is second deviation from ICD DSM that you have to follow. There can be a few more that will come to, I'm sure, as the examples. But these are the few important thoughts that I had in mind. My hope is that these three colleagues and the chairpersons and all of you will have what I have put before you. Thank you so much.
Excellent, I think, start and excellent elaborate viewpoint from President Nimesh's side. I would, I think, extend the discussion further to Dr. Deepak Raheja, taking this concept of dual diagnosis further and forward, specifically when since you are practicing in Delhi NCR region and for a long time. So I think for the benefit of the house, what is the exact percentage of the presentation in our OPDs as well as IPDs, and some tips regarding management issues as well.
So, thank you very much, sir. Thank you, Dr. Sidana, Dr. Rajiv, to have us here for this panel discussion. Thank you, sir, for laying the backdrop of the panel discussion. Dr. Desai sir has laid the foundation for most of the things that are worthy of deliberating. But just taking it forward from there, whether the chicken came first or the egg came first, I think if you deliberate, the whole thing revolves around A to begin with, primary and secondary. B, this whole spiel of certain schools of thought saying, like somebody was mentioning, for 2 weeks don't make an additional diagnosis. Some schools say for 4 weeks don't make a diagnosis. I think unless you have established a diagnosis earlier, that might be worthy of consideration. So let me elaborate. Symptoms, as sir said, immediately during the withdrawals of alcohol. Psychotic symptoms that emanate pursuant to cannabis use, and we see in our clinical practice that the presentation is very florid, there is huge lability, the symptoms speak very fast, and it's almost like what the ICD describes, or originally described in the criteria of what was called as the ATP, the acute and transient psychosis. The settling down also is, I remember Professor Agnoti used to say, like, doodh ka ubal. It goes up very fast, and sometimes the patient begins to settle on day 3 or day 4. I mean, and that obviously has been listed as a good prognostic factor in terms of the symptoms speaking very fast. Psychiatric primary psychiatric illness which is severe with substance abuse which is not so severe. Second group, substance use which is very severe and the psychiatric symptoms or psychiatric morbidity is not very severe. The third group, where the psychiatric symptom and substance dependence both are very severe. So this not dual but triple diagnosis, as was mentioning, which actually get written off. Nobody wants to really sign them off, but they are the ones who really need consideration and treatment from us, and to really coming back to policy as a to get it under the ambit of state mental health authorities, where we will possibly be. I think the ICD or really the current versions not talking about dual diagnosis so much. Number one, like sir said, they conveniently encourage multiple diagnoses. Second, I really want to think if that has to do with also being empathetic in terms of symptom presentation is worthy of ये दिमागी बीमारी है. So एक स्टिग्मा नहीं, अब 2 स्टिग्मा हो गए. तो अब आप किस चीज को राइट ऑफ करना चाहते हैं? You want to write off the dependence issue? So in terms of, I think, treatment, and if we see and relate that chronology to the treatment modalities that have evolved from sequential treatment to parallel treatment to the currently propagated integrated treatment. And like sir said, in the integrated treatment model, there will have to be a leader. And I think by all options that leader should be worthy of a mental health practitioner and ideally a psychiatrist. If there is a psychiatrist, social worker, and all of them have due role to play. But I think also that empathy would entail for psychiatrists. I mean, I remember some interns posted at a particular center and they described that and they're very critical and they watch us more than we watch ourselves. They said this particular doctor smoking cigarette non-stop and telling them, yeah, sharab mat piya karo. Yeah, sharab. That's not going to be enough in terms of the advantages in the armamentarium that we have vis-a-vis the anti-craving medication today. Really think the holistic flavor of the Dr. Gautam was mentioning, the motivational enhancement therapy. That is a very integral part of the treatment and is depictive of an unconditionality that we used to the patient. The cognitive remodulation, the community support, the self-help groups, the 12-step program, and these, mind you me, these are programs that have survived for decades. So I'm sure there is a certain advantage, and there are some beautiful papers which see the psychological paradigm and parameters in the 12-step program. With each step, graduating to the next step, from unconditionality to surrender to a higher power and surrendering for it to cure me. And so it's important for us to be aware that failure is not really a reflection of what we are doing.
To taken care of. So I think all the